So for the purposes of today's discussion, I want to talk a little bit about some of the clinical applications that we've done in the field of using adipose stem cells and using these in different indications. As a quick reminder, BioHeart is a publicly traded company, so I do need to show you these SEC forward-looking statements. What we're doing currently at BioHeart is really a mix of different products, services, and therapeutic pipeline. We have one program that is called U.S. Stem Cell Training, where we offer CME courses for physicians. And the main purpose of this was really to bridge the gap between what's happening in universities, where physicians are learning how to practice medicine, and what's happening in the clinic in the field of regenerative therapies, because there is a little bit of a gap right now, and some of these techniques are not being taught in medical school. So our thought was to offer these courses to physicians so that they can learn about some of the different regenerative medicine techniques and then eventually begin offering these to their patients. The second branch that we're working on is something called vet biologics, and this is where we bring regenerative therapies and stem cell therapies to the clinic for animals, working on large animals such as horses, as well as small animals, dogs, cats, and even recently a skunk. Who knew? People kept them as pets. And then also we have our own clinic where we bring different therapies to patients for a variety of different indications, and I'll share some of that data with you today. And then finally, BioHeart, which is really the parent company, and we have a phase 3 clinical trial working on bringing some different therapies to patients, mostly in the cardiac space, congestive heart failure. So the whole concept of regenerative medicine is harnessing your body's own healing potential to reverse some of the effects that may be caused by diseases. And this may take the form of many different things, gene therapy, even stem cell therapies, and really just harnessing that natural healing response to move forward. And I really consider this the end of the beginning for regenerative medicine. I think we've just begun to scratch the surface of what we're going to be able to do. And one of the things that I think has been problematic for the field is this kind of false hope, and that there's been too much pressure placed on stem cell therapy and regenerative medicine to essentially cure a patient in one dose and the next day they go run a marathon. And I think it's a little bit unrealistic, and I'm not sure when it occurred that we decided that one dose of stem cells was going to be appropriate for patients, because name one drug that you take one of and then you're cured. There's no such thing. So I don't know why that same pressure was placed on the field of regenerative medicine. So I think that it's up to us in this room to re-educate the space and re-educate the public about how regenerative medicine is going to work and not put such high hopes on it. So real quickly, just want to talk about the phases of wound healing, the first being where your body's going to try and create a clot. So the platelets come in and they try to stop you from bleeding out. The platelets also do a lot of important things. They create a cascade of events helping to promote healing and sending messaging to the rest of the body to let them know that something's gone wrong. The second stage is where you get a lot of inflammation, and our bodies tend to overreact with inflammation. Maybe it has something to do with our diets, especially here in Italy, lots of bread and pasta. We eat lots of things that cause inflammation, so our bodies overreact. So what happens is the white blood cells don't really discriminate, and that's probably oversimplifying what happens, but they come in and they wreak havoc. So they mess with the pH, they basically kill everything in sight. And the whole purpose is to make sure we don't get an infection. So that third phase is where there's a lot of interesting things going on, and this is where your stem cells come in and start creating this cascade of events. So you have a paracrine effect or an immunomodulatory effect. Other cells are called to the area. And this is really the phase that we want to enhance. This is one that we want more of. Less inflammation, more of this remodeling, granulation, new tissue formation occurring before we move into the scar tissue phase, which also tends to be too large. So this is really the whole purpose of regenerative medicine, and how can we harness that stage and make it bigger. And real quick on chronic inflammation, the main issue is that we've got too much signaling of that inflammation, and more inflammation creates inflammation. So the last thing you want to do on a patient that has inflammation is put in there more white blood cells that are going to create more inflammation. So these are a few techniques that are currently being utilized in the clinic, and I'm not going to share with you all of the animal studies that led up to some of this work, but just to give you an idea of some of the things that are going on and focusing more on kind of the physician treatments that are going on. By show of hands, how many people are physicians? Okay, and a private practice? Okay, so I guess I'm talking to you too. So there's this concept of using something called bone marrow concentrate, and this is something that you can do in clinic right now. So you take a sample of the bone marrow from the iliac crest, you isolate what is considered the bone marrow concentrate, and then you can reintroduce that into the patient. This is going on in clinics throughout the U.S. and throughout the world. There's a lot of commercially available systems. The main issue with this is that it tends to be very low in mesenchymal stem cells. So the amount of stem cells that are present in the bone marrow is not very high. But the other big issue with this is that it tends to be very high in white blood cells. So if you go back to that healing cascade, the last thing we want to do is add more white blood cells to an already inflamed situation. So if you're dealing with something that's chronic, osteoarthritis or whatever it may be, the last thing you want to do is put something in that's going to create more white blood cells. The second thing that we're seeing a lot in the field is a whole fat graft. This is where you can take some of the adipose tissue and then you can place this directly into a joint. You can't do this IV because adipocytes might create an embolism, but you can put this intra-articularly and maybe into some soft tissue. The issue with this is that adipocytes are where we harbor our toxins. So anytime you eat something that has toxins in it, which we eat all the time, what happens is that goes to the adipocytes and it's housed there. So if you put this inside the joint, what you're creating is more inflammation. So again, go back to your healing cascade. The last thing you want to create is more inflammation. We're already creating enough. Platelet-rich plasma. I think platelet-rich plasma is a huge term that's used probably in a lot of different ways, but there's a lot of different types of platelet-rich plasma. One of the things that can occur when you're taking platelet-rich plasma is that you can get very high amounts of white blood cells, and again, creating inflammation. So really the last thing you want to do in a chronic type situation. I also hear about people doing nebulization of cells, and the whole concept is to get cells into the lungs, maybe help with things like COPD, different lung diseases. The issue with this is that cells are actually rather large in size, 12 to 15 microns, so it's a lot different than nebulizing a drug, which is a very small particle. When you nebulize a cell, these cells can get caught in the mucous membrane, so it's not something that I would recommend, the nebulization. However, what about nebulizing platelet-rich plasma? Platelet-rich plasma is mostly growth factors, things like hepatocyte growth factor. Hepatocyte growth factor has been shown to help to create new lung tissue. I think it's a great idea. Nebulize your PRP. It's the type of thing you could send home with a patient. They could keep it in their freezer and nebulize it every couple days. So this is a natural therapy and a natural way to get growth factors into the lungs. You also hear about placenta and amniotic tissue because some of these are through blood banks or through banks, tissue banks, so they can kind of bypass the regulatory pathway. The issue here is that there's no real living cells. These are typically lyophilized or morselized in some way, so there's no remaining cells, and these are going to be mostly just growth factors. So you're better off using a platelet-rich plasma from the patient themselves. So our preferred techniques in the clinic, platelet-rich plasma, but of course we want to make sure that these are low white blood cell counts. You can use these in joints, soft tissue. You can use these for nebulization, for PRP, and eye drops. These are fantastic. If you haven't tried these, they're great. I use them on myself. So you take the platelet-rich plasma, you mix it with saline. You can use these in eye drops. It's a very natural way to combat severe dry eye. We also like to use something called the stromal vascular fraction. This is the cells that we can isolate from the fat tissue. I'll talk a little bit more about this in the next few slides. And then finally, culture expanded MSC. So again, going back to that concept of when was it decided that one dose of stem cells cured you? I think that's wrong. I think you have to start thinking about multiple doses of stem cells. It's not going to be one and done. And it's not even necessarily going to be 3 doses. We're talking 10, 11 doses. I think it may come at one point in the future where everyone just gets their dose of stem cells every 6 months. You go to your drive-through Walgreens, you get your dose of stem cells, and it helps the inflammation in your body. I don't think we're that far off from that. I think that's going to happen in our lifetime. So let's talk a little bit about adipose stem cells and stromal vascular fraction versus adipose stem cells. So stromal vascular fraction is the mixture of cells that you can get from fat tissue once you've removed the adipocytes or the fat cells, versus adipose stem cells is a small population that is found within the stromal vascular fraction. So these words are sometimes used interchangeably, but adipose stem cells is just a small portion of the stromal vascular fraction. But there's a lot of really important cells that exist inside the stromal vascular fraction. These include things like pericytes, and we now know the pericyte is the precursor to the mesenchymal stem cell. So a very important cell that helps with angiogenesis, that formation of blood vessels. You also have endothelial and progenitor cells that are part of that population. And this mixture has so many different growth factors that are part of it that could really be important in that healing cascade. So this is a quick comparison of what happens when you get a fresh population of cells from fat versus what happens when you get a fresh population of cells from bone marrow. So a couple things. The amount of mesenchymal cells that you can get from fat is significantly higher. So much higher amounts of MSCs from fat than what you can get from bone marrow. And the other important thing is that you can also get high amounts of these pericytes, which we know are the precursors to the mesenchymal cells, and you get much lower amounts of white blood cells from the fat tissue than from the bone marrow. So the bone marrow tends to be very, very high in your white blood cell counts. What's really interesting is that the number of hematopoietic stem cells is actually very similar. And traditionally, we've thought of bone marrow as being our hematopoietic stem cell source, but you can actually get good amounts of hematopoietic cells from the fat tissue as well. So sometimes people talk about, oh, it's so important to use the combination of fat and bone marrow together. Maybe not so important, and maybe you can skip that bone marrow portion because you're not really getting any additional important cells from the bone marrow that you're getting from the fat tissue. And just so you know a little bit about myself, I started out in bone marrow, and I thought there would be nothing better than bone marrow for years and years, and I was resistant to turn over to fat cells, but once I did, I never turned back. Plus, you can never feel guilty again about carrying some extra fat. You can just tell everyone, I'm banking stem cells for later. So what happens when we try to differentiate these cells? So if you go down the pathways of osteogenesis and bone creation, fat actually creates it much better. So this top one is fat, and then the one right beneath it is bone marrow. So fat cells are preparing bone better. Also for chondrogenesis, the SVF formed chondrogenic masses 1 to 2 days, whereas the bone marrow didn't form it until 14 days. So this concept that cells from the bone create better bone is not really true. Don't be tricked just because the name bone is inside bone marrow. So I won't talk too much about the regulatory aspects, but oftentimes people tell me that I might be going to FDA jail if I use stem cells from fat. It's proven not to be true so far, so we've had plenty of visits from the FDA. They're well aware of our protocols. They know the techniques we've used. We've had no issues. We work very closely with the FDA. There has been some FDA involvement in some different groups. Most of these are surrounded with culture expansion without having the appropriate approvals in place to do that. So if you want to talk more about that, or even the guidance documents that were recently published in December, we can talk about that offline. So PRP we mentioned just a little bit before. My preferred technique for platelet-rich plasma is very simple. 8 minutes, 500 G. That's it, 8 minutes, 500 G. What we do is we collect the cells just above where the buffy coat forms, and this is going to be high in platelets but very low in white blood cells. Don't overcomplicate PRP. It's nothing too fancy. It's very simple to do, and you can do this using yellow top blood tubes from BD. So just in case you weren't sure if PRP really worked, this was a split face experiment that we did. We got one of our colleagues to agree to do a split face, and what we did was a laser resurfacing. So basically we burned the skin, and then to half of her face we did small injections of PRP, and to half of her face we did not. So you can see this is the no PRP side. It didn't heal as well as the PRP side. This is 1 week post-injury. At that point, she said, this is a great experiment. Take pictures and now fix the side of my face that we messed up. So we started doing PRP on that side as well. She looks great now. So some of the different areas of research using the stem cells from the fat, really anything where there's inflammation, injury, damaged tissue, because these cells can help to promote repair. So you can use these in many different applications, and all of these spaces are being studied right now in animal studies, some of them in clinical studies, and you're seeing a lot of different groups working on using the adipose cells for many different indications. So I want to share with you some of our results. We do these in aesthetics. So this is a patient where we did something called a stem cell facelift. This is 6 months time difference. So we can fill in the volume. Oh, it's a little hard to see there. It looks much better on my screen. If you saw it, you would think it was awesome, and you would love me. So this is the before. This is 6 months post. One thing that's really interesting about these cells is they're very angiogenic in nature, so they help with new blood supply. So you get this kind of youthful glow. Also can help with collagen production. We do a lot in orthopedics, so these can be osteoarthritis or even acute injuries. Typically what we'll do is we'll mix the PRP with the cells from the fat tissue, and we'll deliver those directly into the joint. This is an example of a non-healing ligament lesion. This is actually on a horse. If I had a pointer, I would show you what I was pointing out. Is this a pointer? Yeah. So right there you can see the non-healing lesion in the ligament. And by 60 days, it's almost completely filled in, and then completely filled in 6 months post. So this was a horse that was considered lame, would have been put down. They had been more than a year with the non-healing lesion, and they were returned to normal work after this therapy. This is an example of a patient with osteochondritis. So you can see here is a chondral lesion. And after intra-articular injection of the cells, complete resolution. This is actually a famous athlete that went back to pitching. This is an example of osteoarthritis. So you can see here the lack of space in the joint. And after an intra-articular injection, you can see the increased space in the joint. These are 3 different examples from a publication. The publication's here. So this is a kissing bone right here. The bone's kind of leaning on, and again, increased space. This is an example of a little lesion. So see this flap right here, and then reintegration of that flap. And then finally, this is a chondral defect right here, and a very smooth chondral layer post-injection. This is all with SVF. We also recently did a small clinical study for degenerative disc disease. What we do is we typically use about 1 cc of platelet-rich plasma plus the cells, intradiscal injection guided by fluoroscopy. And what we discovered is statistically significant improvements in flexion, as well as improvements in the quality of life parameters, VAS and PPI. These are preliminary data, so the full data will be published within the next 6 months. We've done a small study for COPD. In this case, we looked at something called the St. George Respiratory. Patients are demonstrating improvements at the 6-month time period. They're also demonstrating improvements in their exercise capacity. How far can they walk during a 6-minute timed period with statistical significance. In addition, we can deliver cells directly into the heart. We have a catheter system that allows us to deliver cells through the femoral artery and then go directly into the damaged areas of the muscle. So we have 2 different cell therapies that we use for in the heart. One is a muscle-derived stem cell. This will target deep scar tissue because the hope is to create myogenesis or new muscle formation. And we also do with the adipose stem cells or the fat cells. And in this case, what we do is we target the periphery where the healthy tissue meets the scar tissue. And the hope is to create angiogenesis. And so now we can recover some of the functionality of that tissue. So this is the catheter system. And what we demonstrated in our adipose trials is improvement in EF. One thing that's really interesting here is the improvement from 3 months to 6 months. And I think this is really important to educate patients about, that there is a change over time. This is not a quick fix. It's not take a pill and you feel better the next day. It's something that's actually remodeling and changing the course of your disease, and it does take time, and that you will see changes from 3 months to 6 months and even 6 months to a year. We also demonstrate improvements in their exercise capacity. This is a really neat case that we did recently, and so oftentimes what happens is, due to lack of funding, we end up with a lot of N of 1s because we look at different patients. So we've treated over 4,000 patients. Sometimes I consider it 4,000 N's of 1. It's still meaningful data, and I think we have to look at it. So in this case, what we did, the patient had cancer and had been radiated from about the nose down to the chest, and they had destroyed all the glands, and he was no longer able to produce saliva. And oftentimes what happens when you have cancer is your cancer is cured, go home, we're done with you. But the aftermath of the treatments that were done to you to cure your cancer are often horrific. So in his case, he was actually suicidal, was not able to talk or sleep or really do anything. And so we said, well, we'll give this a shot. We injected the cells directly into the glands. We did 4 different glands. And after the first injection, he began to produce saliva, and the glands showed an increase in size. So this is the glands by ultrasound increasing from 2.18 to 3.17 and 1.95 to 3.11. And on the other side, 1.58 to 2.65 and 0.83 to 2.7. So more than double in many of these cases. And this was after 1 injection of SVF. So what we've done is now 2 more injection of culture expanded cells into those glands, and he continues to get better and produce more saliva. So again, this concept of it's not one and done. It's not one dose and hooray, now he can produce saliva. This is going to be a continuous treatment to help improve his status. So this was just a quick experiment that we did. We got 10 of our friends and family to agree to let us burn their arms. And then we attempted to heal those burns using 3 different groups. So we did one that was just a control, one with platelet-rich plasma, and one with platelet-rich plasma plus adipose stem cells. It's very difficult to be my friend or family member because you get tortured a lot. So this is what one of the arms looked like. So this right here is the control. This was with platelet-rich plasma by itself, and this was platelet-rich plasma plus the stem cells, so you can see how much better the healing was with the stem cells plus the platelet-rich plasma. I'd actually like to add a 4th group here where we just look at the adipose cells by themselves to kind of compare to PRP to see what happens there, but I've run out of friends. So this is an example of what we can do for things like limb ischemia. This is actually just an N of 1. We did radiation necrosis, and we published this case study. So what we did is the patient had this non-healing ulcer wound because they had a cancer, and they did maximum billable amount of radiation to the leg until they destroyed all the vasculature in her leg and was left with this gangrenous putrid wound. And the physician said, at this point, there's really nothing that can be done. We must amputate the leg. So we said, as a last-ditch effort, we'll do an introduction of the SVF plus some platelet-rich plasma. With just 1 introduction, she did get complete healing. So this is 8 months post, and this is the before and after angio. So this is the before leg. The radiologist reported identical blood flow in both legs. So just 2 more cases I want to share with you. This was a patient who had lost their fingers because he was working on the motorcycle and got his fingers caught in a chain. And so when he presented to us, you can see it was actually pretty gangrenous, and they were going to do some more surgery to remove tissue. So our goal at that point was to try and prevent additional amputation. We introduced the cells. When he went to his surgeon 3 days later, they canceled the surgery. They did not amputate further. What came as a surprise to us is that 3 weeks later, he began to grow a nail back, and this was 6 weeks post. And over a 6-month time period, we've grown 1 centimeter on both fingers. We're doing an introduction of cells once per month, and the goal is to keep him in the regenerative state. Don't allow it to go to that scar tissue, fibrotic tissue, because it'll stop growing. If you think about a lizard, it takes 2 years to grow back a lizard tail. So it makes sense that we would have to keep going with this. And why not try? Why not? So this is the final case I want to share with you. This was a patient who presented to us with a spinal cord injury, and he had no movement of his hands. He had no movement from waist down. He was not able to walk, obviously, or even move his legs at all. So we did an intrathecal delivery, a lumbar puncture in the lower portion, and the thought is that it would travel along the cord and maybe heal some of the nerve damage there. After 1 dose, nothing happened. 2 dose, nothing. It wasn't until the 8th dose that he started to have movement of his legs and was able to get up and walk. I don't know. I have a video here. Let me just see if I can get this video to play. So this is him now, and we've done about 10 doses, and we do these about every, oh, okay, hold on. Can you see this? We do the doses about every 6 weeks. It's not 1 dose. It's not. It's not going to help a patient like this. One and done doesn't work. So since this time, we've done 3 more spinal cord injury patients. So an N of 1, but a pretty powerful N of 1. And I think it's important to keep redosing these patients. So just I'll leave you with one more thought. The concept of regenerative medicine is really here to stay. It's going to change the field of medicine as we know it. It's going to be really important in our lifetimes. We're going to effectively change the course of a lot of different diseases, and more conditions are being successfully treated with regenerative medicine. And you have an opportunity to make a substantial clinical impact on patients who are suffering from different degenerative diseases. So I encourage you to get involved with this field, as you obviously are. Last thing, I'd like to leave you with my email. I do a free journal club once per month, and I have all the recorded webinars as well. So please send me an email, and I'd love to have you as part of our network. Thank you.